Thank you very much and good afternoon. Welcome to the ASCO-sponsored session. So for this afternoon, we will discuss doing what's best for your patients, putting the latest findings from the 2022 ASCO annual meeting into practice in low to middle income settings. So before we start our session, I want to introduce our reactors. Dr. Jane Brock. Dr. Brock is the Chief of the Breast Pathology Division, Brigham and Women's Hospital, the second largest teaching hospital of Harvard Medical School in Boston, Massachusetts, USA. Another reactor is Dr. Priscilla Kagiwa. Dr. Kagiwa is the Chief Section of Medical Oncology of University of Santo Tomas Hospital and Associate Professor at the Faculty of Medicine and Surgery of U.S.A. And we also have Dr. Gary Lorenzo. Dr. Gary Lorenzo is a medical oncologist of Healthway Cancer Care Center. So without any further ado, let's kick off this session with Dr. Julie Gralow. Dr. Gralow is currently the Chief Medical Officer and Executive Vice President of American Society of Clinical Oncology and the founder of the Women's Empowerment Cancer Advocacy Network and supports patients advocates in low and middle resource countries.
Good afternoon. Welcome to this ASCO-sponsored session. As Roselle just told you, I'm the Chief Medical Officer for the American Cancer Society, but I also spent 25 years as a breast medical oncologist, so it's appropriate to be here at a breast symposium. If I could have my first slide, please. During this session, you will hear 3 formal presentations of some exciting information that came out of the ASCO 2022 annual meeting. And our goal, with Roselle's help at all, is going to try to put this in perspective into a low and middle resource setting. I've been asked to describe a trial called the Destiny Breast 04 trial, which is looking at an antibody-drug conjugate that targets HER2 and that has chemotherapy linked to it, but that interestingly, in this trial, this drug, which is already approved for the treatment of HER2-positive breast cancer, was shown to have activity in a new category that we're calling HER2-low breast cancer. So, if I could have the next slide, please. This is a slide that shows this group, which is the majority of breast cancers, about 80% of all breast cancer that we previously called HER2 negative. And this shows what the treatments in metastatic breast cancer were for that group prior to this study that I'll be describing. In the HER2 negative but hormone receptor positive group, of course, we have endocrine therapy, tamoxifen, the aromatase inhibitors, fulvestrant. We have those drugs used in combinations with CDK4/6 inhibitors, PIK3CA inhibitors, mTOR inhibitors. We have chemotherapy, and in the BRCA positive, we have PARP inhibitors. And then there's another category of what was called HER2 negative that was also negative for endocrine therapy. And so we had chemotherapy, immune checkpoint inhibitors if the tumor has PD-L1 expression, another antibody drug conjugate called sacituzumab govitecan, and again, PARP inhibitors in the BRCA positive. And this doesn't seem to be working. I don't know if it's a battery. If I could have the next slide. So those were the treatment options for what we used to call HER2 negative breast cancer. And in HER2 positive breast cancer, at least in the United States, we currently have 8 FDA approved drugs targeting HER2. 3 of them are just antibodies. Another 3 are oral tyrosine kinase inhibitors, and 2 of them are antibody drug conjugates, the antibody being essentially the same as trastuzumab or Herceptin, but with chemotherapy linked to it. So lots of choices in the treatment of HER2-positive breast cancer. Next slide. Next slide, please. And going into more detail, this is the drug I'm going to be talking about, trastuzumab deruxtecan. We call it TDXD, as well as an abbreviation. The antibody piece of this antibody drug conjugate is essentially the same as trastuzumab. And then it's linked to a chemotherapy, a very potent chemotherapy that falls in the class of a topoisomerase I inhibitor. And what you can see in the little cartoon here, which is a little bit small as I look back at this, is that the antibody gets into the cell after binding to the HER2 receptor on the surface of a HER2 positive cancer cell. It gets internalized, it gets cleaved. Now chemotherapy is released inside the cancer cell, and then a bit of it does leak back out again, which is attributed to some of its side effects. Next slide. This is the schema for the DESTINY-Breast04 trial. We already had this drug approved in the treatment of metastatic HER2-positive breast cancer, but early trials had shown that when there was lower level of HER2 expression in a range that we technically previously called HER2 negative, that there was some activity. So the patients that were enrolled in this study had either immunohistochemistry 1+ or immunohistochemistry 2+, with in situ hybridization being negative, a group that we would have previously called HER2 negative. But they're now calling this HER2 low. And these patients all had been previously treated with endocrine therapy with 1 or 2 lines of chemo, and they enrolled in the trial being randomized to trastuzumab deruxtecan or a chemotherapy agent of the physician's choice. And you had a choice of 5 different chemo agents, because this would be standard of care at this point for these patients. And the primary endpoint was progression-free survival in the hormone receptor positive subset. And this shows the primary endpoint, progression-free survival. You don't have to use a microscope to look at the difference between these curves. Over on the right is the hormone receptor positive. On the left are all patients. And clearly you can see that there is a significant difference in the curves for progression-free survival in favor of the TDXD, the trastuzumab deruxtecan arm, as compared to standard chemo. And here's the overall survival. Obviously, the key most important endpoint, patients who received the TDXD lived longer, on average of about 6.5 months longer than those who were randomized to get just standard chemotherapy. And this is just to show you that responses were seen both in the hormone receptor positive HER2 low group as well as the hormone receptor negative HER2 low group. And you can see that the group that got the trastuzumab deruxtecan had about 50% response rates, and the group that just got the standard chemo was closer to 16% response rates, a real dramatic difference. And I'll point out that although compared to standard chemo, you might think an antibody drug conjugate that's delivering chemo inside the cell could be a little less toxic, that's not necessarily the case here. The toxicities are just different. So there's more nausea with the TDXD as seen in this trial, but more neutropenia with the standard chemotherapy. And there were more dose discontinuations that were seen for the TDXD. So this is not a benign, non-toxic drug. It's just the toxicities are different compared to standard chemo. And then there is one main toxicity that is unique to the antibody drug conjugates, this interstitial lung disease or pneumonitis. About 12% of the patients on the TDXD arm had this lung toxicity, interstitial pneumonitis, and there were a couple that were fatal. And there was only a very rare case of pneumonitis in the chemo arm. And then HER2 agents in general are associated with some cardiotoxicity, so that was also looked at. And about 4.3% of patients who received TDXD had some heart failure or a drop in ejection fraction, and there were none in the traditional chemo arm. Now, these can be monitored and should be monitored, and stopping the drug early, you don't get the serious grades of these toxicities, but this is something that needs to be monitored. So with the results of the DESTINY-Breast04 trial presented at the ASCO annual meeting in June of this year, the FDA by August approved TDXD, trastuzumab deruxtecan, in this new HER2 low category, which is about 45 to 55% of all breast cancer. And ASCO rapidly updated our guideline in this category about the same time as the FDA approval and said, yes, for the HER2 1+ or IHC 1+ or IHC 2+ that is negative for in situ hybridization, we are recommending that this could be considered a reasonable treatment. So we have a new treatment option. You go back to the treatment options for HER2 negative breast cancer I showed, and somewhere we have to figure out where we're going to fit in trastuzumab deruxtecan into this. Now remember, the hormone receptor positive all had prior endocrine therapy and had 1 or 2 lines of chemo, and the triple negative all had 1 or 2 lines of chemo. So it's not really been tested in the very first line setting. So our topic of this session was, how do we put this into practice in low and middle income settings? I'll say trastuzumab deruxtecan is a new treatment option for nearly half of all patients with metastatic breast cancer. There's demonstrated activity of this agent, but caution, it doesn't necessarily translate to other HER2 agents. So don't think that because this was a positive trial that trastuzumab or lapatinib or tucatinib will work, okay? It's not necessarily translatable to all HER2 drugs. It has toxicity. It's not necessarily less toxic than chemo. And exactly where this drug should be used in the treatment lineup is unclear. And the issue here is this drug is likely only immediately accessible right now in the highest income settings. It's expensive. And so the challenge here, and some of our discussion will be, how do we get access to key critical drugs like this that really have efficacy? Patients live longer here and offer new treatment options. How do we get access to it globally? And we also need to reconsider breast pathology if there's a clinical reason. So in the United States, if I have this drug available, I want to really know who falls in this category, this HER2 low category. But if I don't have access to this drug, it's a little bit irrelevant right now to try to sort out that category. And the issue is that in the lower ranges of HER2, the pathologists haven't worked hard to figure out the 0 from the 1+, for example, because it never meant any clinical relevance. It never had clinical relevance. You know, we didn't have drugs that benefited from these lower levels. So we've got our pathologists here. They're going to have to work out how low can you go? What is the real cutoff for HER2 low? So thank you very much, and I'm looking forward to an interesting discussion.
Thank you very much, Dr. Gralow, for highlighting what is the difference of trastuzumab deruxtecan with the standard trastuzumab that we've been using for decades now. And later on, we will be discussing more about the implications of this new drug and its use in our local setting as well as in the rest of Southeast Asia. So our next speaker is Dr. Dawn Dizon. Dr. Dizon is a professor of medicine at Brown University, director of women's cancers at Lifespan Cancer Institute, and director of medical oncology at Rhode Island Hospital. Dr. Dizon is a medical oncologist specializing in the care of women with breast and gynecologic cancers. He's also particularly working on survivorship as it pertains to sexual health for men and women with cancer, patient engagement, and social media. Dr. Dizon?
Thank you very much. It's a pleasure to be here in the Philippines. As any good Filipino son does, I brought my mom with me. All right, so I was tasked with providing an update on hormone receptor positive breast cancer. If I can have my slides. All right, and I'm going to focus really on exactly the population that Dr. Gralow talked about, the people living with metastatic breast cancer that is hormone receptor positive. It is the most common of the subtypes of breast cancer that we see. And for people with metastatic breast cancer and for people newly diagnosed with breast cancer that is hormone receptor positive, we know that hormone blocking therapy or endocrine therapy is the mainstay of treatment. For people with metastatic breast cancer in the United States, the use of a new class of drugs called the CDK4/6 inhibitors is a new standard of care. So it really did change the way we treat metastatic breast cancer. And in the United States, we have 3 of those drugs available: ribociclib, palbociclib, and abemaciclib. Very busy slide, but again, to remind us all that before a drug gets approved in the United States, there's a series of clinical trials that we need to do. In the phase 1 context, we're not looking at response rates or survival. We're taking a drug that seems to be very interesting, and we want to see how toxic it is. So in a phase 1 trial, although we hope there's a benefit to patients, our goal is to find out how much of that drug we can deliver and to say more comfortably what kind of toxicity are we exposing people to. Once we get that information, we go to a phase 2 clinical trial in a very specific population, as you'll see in this very busy slide. And really there, it's to see how well does the drug work in a particular group of people. In this case, we looked at these CDK4/6 inhibitors in people with hormone receptor positive breast cancer. And when the phase 2 is positive or interesting, we ask if we should change our standards of care. And that's the phase 3 clinical trial. So what you're seeing in this slide is what has been done with abemaciclib, palbociclib, and ribociclib. The palbociclib trials have been called Paloma. The abemaciclib trials, Monarch, and the ribociclib trials, Mona Lisa. And if you look at the very last slide, last column, it's OS. That's overall survival. That is how many people were alive and how long were they alive. And for anyone living with metastatic breast cancer, that's often what they want to know specifically. But if you are having symptoms related to your metastatic breast cancer, especially pain, it might be more important for us, your doc and you, to focus on the response rate. Because if I can reduce that burden of the disease, I'm hoping your symptoms will get better. And it might be important to look at things like progression-free survival, or how long does the cancer stop growing? Because maybe that will get you to that wedding you want to go to, or that vacation you want to go to outside of the country. And it really wouldn't matter if you survived longer on this drug. So again, we had a very interesting conversation about the goals of a person being treated and where the oncologist fits in to make that goal. And not all of these drugs are showing benefits in all three of those areas. Universally, CDK4 inhibitors, when compared, CDK4 and 6 inhibitors with anti-hormone therapy, when compared to anti-hormone therapy alone, have showed consistently, I can improve progression-free survival. I can improve the time your cancer isn't growing. And I can improve how well that treatment will work, the response rate. But not all of these trials have shown whether I'll have you live longer, okay? And we also have some unresolved questions. Say you got one of these CDK4/6 inhibitors with hormone therapy, and then you progressed. What's the right next step? Do you continue the CDK4/6 inhibitor and maybe change out the partner? Or can you just change out the CDK4/6 inhibitor and continue the endocrine therapy? That was one of the major questions that was resolved at ASCO, or started to. And it was in a trial called Maintain. And this trial took people who had HER2-negative breast cancer that was hormone receptor positive, who had received a CDK4/6 inhibitor with endocrine treatment and had progressed. They could have even had a cycle or a round of chemotherapy and progressed. All of these patients were rendered postmenopausal. So if you were a young woman still menstruating and had metastatic breast cancer and progression on a CDK4/6 inhibitor, or despite progression on chemo, you could still go on this trial provided I silenced the ovarian function. So here it was a randomization to either ribociclib and a switch of the endocrine therapy. So if I had you on a drug called, say, letrozole and, say, palbociclib, I could put you on this trial and give you ribociclib and fulvestrant. Or you could have been randomly assigned to just the endocrine therapy. So stop CDK4/6, put you on a different kind of anti-hormone treatment. So they screened 170 people. If you look here, about 120 people were treated on this trial. And this is the population they were treated. It was, the median age was 59. Most of these people were female. Most of these people were white. The Asian population represented about 11% on this trial. De novo metastatic disease, meaning you presented for the very first time with bone metastases, liver or lung involvement of your breast cancer, was in about 35%. And about 10%, give or take, received chemotherapy. All of them had prior CDK4/6 inhibitors. Most of these patients came into this trial having received palbociclib, which to this point, even in my own clinic, had been the drug that I'd used more commonly. And the median duration is important. So first line use of CDK4/6 inhibitors and anti-hormone treatment, people stayed on that for 1.5 years, almost. So it worked. So this was a group who were endocrine therapy responsive and seemed to benefit from a CDK4/6 inhibitor as well. And this is what they demonstrated here. And so the way you can read this is that with continuation of a CDK4/6 inhibitor and endocrine therapy after you progressed on that same kind of treatment, the benefit was about 3 months. So it was 5.8 versus 2.76, that very big number on the left here. Just concentrate on what it says, 95% CI. If that CI does not cross 1.0, then this is a statistically significant result. So the docs in the room will tell you this is a significant result. The patients in this room, those living with the disease, will let us know if 3 months is important to them. It's the difference between clinical significance and statistical significance. And in regions like this, where cost is significant, it becomes a more important discussion. So at 6 and 12 months, this is another way you can look at these results. Suffice to say, the benefits were seen and demonstrated if you continued the CDK4/6 inhibitor. It was seen no matter what the choice was between the hormone therapy partner, and it seemed to really help in patients who received palbociclib, and then we're getting on to ribociclib. In that blue box, you're seeing in the ribociclib-treated people, again, not a definitive statement at all, but that number is crossing 1.0. So not a significant finding here, suggesting ribociclib up front with progression, followed by ribociclib, might not be a good choice. Suggesting it, not confirming that. Again, the benefit of ribociclib in combination, higher response rates and higher clinical benefits. Responders, stable disease, and those who seem to otherwise do well. The adverse events were neutropenia, as noted here. So the take-home points was that CDK4/6 inhibition seemed to still be important. So we're going to take this forward and hopefully see more definitive trials going forward. To wrap up, we'll just look at the PALOMA-2 trial because they presented us with the overall survival results of this phase 3 trial, which looked at what I do in clinic, palbociclib plus an aromatase inhibitor versus just an aromatase inhibitor in people with metastatic or advanced breast cancer. This was the statistical design. So you could enter this trial with prior hormone therapy, progressed, but could not have been treated for that progression. That's who they were looking at here. It was a first-line clinical trial. Unlike the trial maintained, this group was on average in their 60s. And in terms of the survival disposition, the only thing to point out here is that the survival analysis lacked the data in almost 20% of people. Remember that as we look forward. So if you look at the results, compared to just letrozole, there was no survival advantage to the combination. Palbo and letrozole did not help these patients live longer. That is the overall survival. But if you look at the median, the cutoff point where people were still alive, you're approaching 55 months. These patients lived for years. We couldn't really tell, was there a group that potentially did better in terms of toxicities? There was no new signals that were seen. So use of palbo and letrozole resulted in a median survival of 53 months that was not significantly different from letrozole alone, but that median overall survival is better than we've seen historically. Historically, it was about 3.5 years. In these modern trials, you're seeing a survival over 15 months, 50. And palbo and letrozole was durable. You saw in the ribociclib arm, people entered that trial, they were on that treatment for 15 months. Here, they had someone on these trial for over 7 years. Other CDK4/6 inhibitors, however, have shown a survival advantage, including palbociclib with fulvestrant after progression on an aromatase inhibitor. So a second or later line hormone therapy. And in the Mona Lisa trial of ribociclib plus fulvestrant, that was also positive for survival. So the totality of data indicate that people with hormone receptor metastatic breast cancer should receive a CDK4/6 inhibitor at some point during treatment. I think that is, I'm quoting directly by something that Dr. Gralow said in one of our prior meetings. Global advocacy, we need to bring these drugs to people no matter where they live. The sequence, the mechanisms, resistance, novel treatment partners that we can use, this is what we're continuing to investigate. Thank you.
Thank you, Dr. it's really relevant at this time that most of our patients are still receiving, whether premenopausal and postmenopausal, of course, they're still receiving tamoxifen. And the data on the Paloma trials, Mona Lisa, and Monarch trial are really pushing for the use of CDK inhibitors with aromatase inhibitors or in combination with GnRH analog for premenopausal. So I believe there will be so many discussions and questions that we will be receiving for our participants on how to put the use of CDK inhibitors in the perspective of somebody from this region and in this country. Not only the cost, but also some side effects, toxicities, and the differences in scheduling. And the more questions that we are getting with the availability of all the CDK inhibitors, questions on sequencing, as questions on how do we maximize which drug first to use and what are the other options or approaches or strategies eventually when patients progress, okay? So now I will turn you over to Dr. Mylin Torres for the next presentation. Dr. Torres is a professor in the Department of Radiation Oncology at Emory University School of Medicine at Atlanta, Georgia, USA. She serves as co-leader of the Cancer Prevention and Control Research Program at Winship Cancer Institute of Emory University. Dr. Mylin Torres.
Thank you so much for the opportunity to be here. Thank you, ICANSERVE Foundation, Global Focus on Cancer, and ASCO for inviting me to talk today. We're going to switch gears. I'm a radiation oncologist, as Roselle mentioned, and I will be talking about metastatic breast cancer, but really the role of radiation in this disease. My first slide, please. So specifically, I'm going to be talking about a seminal trial known as ENERGY-BR002, which really held a lot of hope for us as breast cancer radiation oncologists, and I'll talk about why we thought that this could be something that could be could really change the standard of care in radiation. These are my disclosures, none of which are relevant to today's presentation. So to give you some background, a very common but underutilized use of radiation treatment is really to palliate symptoms in patients with metastatic breast cancer. And when I say underutilized, even within the United States, anywhere from 50 to 70% of patients who need palliative radiation for bone pain, neurologic symptoms, bleeding, fungating tumors, they don't receive it. Primarily maybe because they're not referred in a timely manner, there's not an awareness of how radiation can help them, and even access to care. That number is even lower in lower middle income countries, where about 10 to 30% of patients who need palliative radiation receive it for the same reasons that I just mentioned. When we think about radiation for metastatic breast cancer, traditionally we've always thought of it as when we treat a lesion, it leads to regression of the treated metastatic disease as would be expected, but there really is no impact on progression or development of new metastasis outside of the radiation field. When we think about how much radiation to give a patient, there have been multiple trials, even in the Trans-Tasman Radiation Oncology Group based out of Australia and New Zealand, as well as the RTOG based out of the United States, indicating that one dose of treatment is equivalent to multiple doses of treatment. In radiation oncology, we call doses fractions, the number of treatments. When you look at a meta-analysis of trials looking at single fractions versus multiple fraction treatment regimens, over 26 randomized trials with level 1 phase 3 data, the data that we use to actually indicate whether we should do a treatment or not, with over 6,000 patients, they all indicated that there were equivalent complete response rates to pain if you give a high dose of radiation treatment one time versus multiple treatments. Therefore, in lower middle income countries, even where I practice, where we have a number of rural patients who have difficulty with transportation or comorbidities, a single dose of radiation can be very effective if the patient can come in for treatment in that era. Sort of pushing the envelope, in recent years, people have been looking at whether more advanced technology, namely stereotactic body radiation, may be used to improve the response rates of pain, particularly bone pain. One of my colleagues, Dr. Nguyen at MD Anderson, conducted a phase 2 trial looking at SBRT, the stereotactic body radiation, versus multiple fractions of standard 3D conformal radiation to find out if higher doses of radiation that's more targeted, conformal, is better for the patient than our traditional radiation treatments. She took patients who had any type of metastatic breast cancer, lung cancer, colon cancer. Patients were randomized to receive either 30 gray and 10 treatments. And to the right of that, you'll see here, essentially 3D conformal radiation involves radiation that's not as focused. You have a beam coming from the back side of the patient, one coming from the anterior side of the patient, and inside of it, you'll see a topographic dose distribution. Looking in, you'll see that dose not only gets to the target, which is the vertebral body or the spine on the back of that CT image set, but it also goes through the lung and the heart and the contralateral breast. That's what happens with 3D conformal radiation. On the bottom panel, patients were randomized to what's known as stereotactic body radiation treatment. It can be given with IMRT, which is intensity modulated radiation, or VMAT, volumetric modulated arc therapy, where essentially you're giving arcs of radiation treatment, small doses at each degree, to really get that dose super tight around your target and make sure that you minimize the dose to the normal tissues around it. Because when you're giving high doses, you clearly want to avoid things like the spinal cord because you could potentially paralyze a patient. And in this case, the doses were elevated at 12 gray or 16 gray to those bony metastatic disease. So in this trial conducted at MD Anderson, they found that the single fraction, high-dose treatment with very advanced technology significantly improved pain relief when compared to the multiple treatments given with our traditional radiation treatment. And this result was seen at 2 weeks, 3 months, and 9 months after radiation, indicating that this could be the wave of the future. In addition to these studies, there have been several studies looking at how women with metastatic breast cancer do generally. What we know from these studies is that generally a smaller number of metastatic lesions, 4 or less, also known as oligometastatic disease or few metastases, is better than in patients who have a larger number of metastases or widespread number of metastases. After treatment is given for localized breast cancer with curative intent, we know that women who have metastatic disease that develops after a prolonged period of time is better than metastatic disease that arises quickly and within a short interval. Thirdly, we know that hormone receptor positive breast cancer that is spread to the bone only is more favorable than disease that is spread to the viscera. And in medical terms, that would be liver, lung, or brain. Although there are some exceptions, particularly with new targeted therapies in triple-negative breast cancer as well as HER2-directed breast cancer. So given this background, Energy BR002 was developed knowing these 3 principles. It was a phase 2R3 trial of standard of care systemic therapy with or without stereotactic body radiotherapy and or surgical resection for newly oligometastatic breast cancer. It really proposed a new treatment paradigm. It recognized that women with limited metastatic breast cancer, 4 or fewer lesions, those who have oligometastatic disease, have really a different natural history than those with more extensive disease. They tend to do better. So the idea behind this trial was, could we use radiation, specifically very high doses of radiation, to metastatic disease that's few in number, 4 or less, to prevent disease from arising elsewhere in the body, the so-called abscopal effect, which is a scientific term which it basically means that when you treat one area, the effect of radiation is not only within the radiation field, but it actually can lead to regression of tumors outside of the radiation field by enhancing the immune response to radiation treatment itself. So the whole notion was that ablative therapies with very high dose radiation or surgery could improve progression-free and overall survival in patients with oligometastatic disease by preventing progression of known metastasis and development of new lesions elsewhere. At the same time that Energy BR002 was accruing patients, the SABRE Comet trial was published out of Canada. This looked at stereotactic ablative radiation doses, basically SBRT, and it looked at a number of patients with a variety of malignancies. 18 of 99 enrolled patients had breast cancer. In this study, it looked like overwhelmingly, if you look at the curves, the red curve in particular is those patients who received SABR or SBRT, they had significantly improved overall survival, indicating that there was hope that maybe this strong dose of radiation could help patients long term. Of course, with everything, we have to look at the cost. In this trial, 5% of patients developed a fatal adverse event. So in our world, that's not good. So that's one thing that we were worried about, is by giving these high doses of radiation, are you also harming patients, which is something we obviously want to avoid. When that was published, NRG-BR002 was also enrolling patients, but specifically only patients with oligometastatic breast cancer. The trial was controlled to include only patients who had very controlled local regional disease, meaning that they had disease that was well controlled within the breast, as well as the ipsilateral lymph nodes, so they were treated to those sites. And they had to have less than or equal to 12 months of systemic therapy without progression of disease. So they were cherry-picking patients who didn't have particularly aggressive disease. They stratified the patients based on metastasis, the number of metastasis, hormone receptor status, HER2 status, and whether chemotherapy had been given for metastatic disease previously. Patients were randomized to arm 1, which was standard systemic therapy with radiation or surgery reserved only to palliate symptoms, or arm 2, where standard systemic therapy was given, but total ablative radiation was given or surgery to 4 or fewer metastases, and those METs could be symptomatic or not. In terms of statistical design, it initially started with a phase 2R randomized study, which looked at metastatic directed therapy of all visible lesions with systemic therapy, looking for a signal that this could improve progression-free survival, specifically from 10.5 to 19 months. If it did, then that was the go signal. The go signal meant that the arm with the ablative radiotherapy would continue on to be compared to systemic therapy to answer an overall survival question in a phase 3 trial. It's important to note that these doses at the time were unbelievably high and made people nervous to enroll patients on the trial, to be frank with you. 50 gray and 5 fractions to the lung were administered, 45 gray and 3 fractions. We're talking 3 to 5 times higher than what we would traditionally have given. The doses were derived from NRG-BR001, a preceding trial. The first patient, importantly for each metastatic site at each enrolling institution, were reviewed in real time by very thorough and rigorous quality assurance and by experts in radiation oncology. I say all this to emphasize that these were the highest biological doses of radiation ever given on a trial. Therefore, it was the most quality assurance ever used in a metastatic trial to maximize safety and efficacy to the patients who trusted us and were enrolled on this study. In terms of patient and tumor characteristics, there were 125 patients. The vast majority of the patients, 60%, had only one site of metastatic disease. Almost 80% of the patients had hormone receptor positive, HER2 negative disease, extremely favorable. If you look at the spectrum of patients with metastatic disease, these were the favorable players. In terms of treatment, as you recall from the protocol, you could get SBRT, which is the radiation or surgery of the site of metastatic disease. Over 90% of providers elected for radiation rather than surgery. In terms of systemic therapy, 60 to 80% of patients got hormonal therapy reflective of the hormone receptor status of that disease, and about a third received chemotherapy. Now, while I said we had very high hopes for this study, because as a breast radiation oncologist, we'd like to have a systemic impact, obviously, in prevention of distant disease, unfortunately, we were disappointed by the results. In terms of the primary endpoint, looking at progression-free survival, there was essentially no change and no improvement in terms of progression-free survival with these high doses of radiation. The median progression-free survival, in terms of 50% of patients being alive at a certain time, it was 23 months with standard of care, versus with radiation, it was 19.5 months. In terms of overall survival, the story was the same, with ablative therapies having no impact on improving overall survival. When you looked at where patients were failing after radiation, the numbers were the same no matter which arm you were in. 40% of patients developed a new site of metastatic disease outside of the radiation field. In patients who did receive radiation, they had significant regression of the tumor inside of the radiation field when compared to standard of care. Now, in terms of toxicity and quality assurance, one thing that was of benefit from this trial that we found is essentially that the toxicity was not as bad as on the SABR Comet. There were no grade 5 fatal toxicities, and only 2% of patients developed a grade 4 toxicity, and that was in the arm that didn't receive radiation. And a large part of this was because of the very rigorous quality assurance that was instituted by the Energy Oncology to enroll patients on trial, as well as the tight dose constraints that were rigorously QA'd before treatment was ever given to a patient. When they looked at whether there were subgroups of patients that could benefit from high-dose radiation, there really wasn't a signal, perhaps in patients with more than one site of metastatic disease, but the numbers were small and it's really hypothesis generating. So in terms of conclusions, patients with oligometastatic breast cancer, again, those patients with 4 or fewer sites of disease, have long progression-free and overall survival. High-dose SBRT was safe with low rates of treatment-related adverse events, similar to the standard of care, owing largely to the quality assurance and the dose constraints that were instituted on the protocol. Metastatic-directed therapy, however, failed to improve progression-free survival for these patients. Therefore, there was a no-go signal to move it to a phase 3 study. So in terms of take-home points, what we knew traditionally is still true today. Radiation clearly palliates symptoms, pain, bleeding, ulcerative tumor, neurological symptoms, sensory abnormalities. A single fraction of radiation, 8 gray times 1, is effective and convenient for improving pain due to bone metastasis and improves access to care. Recent phase 2 data indicate SBRT is a promising tool for delivery of high-dose radiation to palliate bone mets, but phase 3 data is still lacking. SBRT ablative treatment, however, does not improve prolonged survival in patients with metastatic breast cancer in that group of patients enrolled in Energy BR002. I'd like to acknowledge our patients who are courageous enough to enroll on our clinical trials, Dr. Steve Shimmer, who was the PI of the Energy BR002 and who was kind enough to provide me with his slides, Dr. Nguyen, who's the PI of that MD Anderson study, and then Energy Oncology. And with that, I thank you.
Thank you, Dr. Mylin. And for everybody's information, we'll also be joined by Dr. Mei Ling Yap. Dr. Mei Ling is a staff specialist radiation oncologist and director of training at Liverpool and MacArthur Cancer Therapy Center in Sydney, Australia. Dr. Mei, can you hear us? So thank you again, Dr. Mylin, Dr. Dawn Dizon, and Dr. Julie Gralow. Yes, can you hear us?
Yes, I can hear you.
Thank you. So may we invite Dr. Brock, Dr. Kagiwa, and Dr. Lorenzo as our reactors just to kick off our discussion. For those patients who are listening and tuning in virtually, I think what is important is after listening to those data and research information and findings, how important it is the new drug, trastuzumab deruxtecan, and CDK inhibitors, and the different approach on radiation therapy, how important it is for an ordinary patient with breast cancer.
Let's see if this is working. Let me turn this mic on.
Hello.
Here we go. Thank you. I would also throw the question out to our colleagues in the audience. In the United States, we have FDA approval, we have insurance coverage for this. It's offered another treatment option. It's important. This was one of the few trials we showed where patients lived longer if they got this drug as opposed to one of 5 other chemotherapy agents. So this is an important drug it is also not available in most places in the world. And so we talked about, the question would be, how are we going to get these expensive drugs, the CDK4/6 inhibitors, these antibody drug conjugates, so they're accessible around the world. I will tell you, at ASCO, we did a survey in 2021 of our international members and said, what is the thing that ASCO can do to best help you do your job in helping your patients? And we gave lots of choices, and number one was access to essential drugs. I will tell you, number two, Isabel, was registries, and number three was access to the pathology in order to decide on the treatments. And so this is what our members are saying ASCO should be helping with. And as part of that, and we can talk about it now or later, we have joined with the Union for International Cancer Control in the ATOM Coalition, Access to Oncology Medicines Coalition, which we just launched at the World Health Assembly in Geneva in May, where we are working with lots of stakeholders, the generic and biosimilar makers, and actually the industry making the originator drugs still on patent. And we're working with the Medicines Patent Pool, and we're working on ways to get at least the drugs on the WHO's essential medicines list, but also other drugs that don't make the WHO's essential medicine list only because of cost, not because of efficacy or toxicity, but solely because of cost, and getting access to those drugs. And we're going to start with between 5 and 10 countries as a pilot. We're going to start with breast cancer as the first disease to try to get the drugs approved, and then we'll branch out to other common cancers. And this is one way where we're hoping for low and low middle income countries anyway to get these very important drugs that are helping patients live better lives and live longer lives available, because it is just not fair, the inequity in access to care that's going on around the world with respect to cancer.
Talking about Dr. Dizon.
Oh, no, I agree wholeheartedly. I mean, I think the approach to metastatic breast cancer, there's no singular right way to treat it, but it really helps conversations if there's a menu. And that menu should be afforded to everybody across the world who's trying to live with metastatic breast cancer. But, you know, we were talking earlier about how, you know, if you have the impression that people in the United States have equal access to all of these drugs, you would also be wrong. And Mylin actually mentioned that we fight for access to these drugs for our patients in clinic every day. There's a whole new specialty that supports us to try to get access. And it isn't easy.
Yes.
I'm Ching Ha Yip from Malaysia. I'm a breast surgeon. Julie, very nice to listen to your talk. You say in Malaysia, in the adjuvant and metastatic setting, we also have problems, you know, getting Herceptin, trastuzumab, to the patients. And I have patients whom we send to the government hospitals for Herceptin. There's a waiting list, there's a budget, so there's a certain number of patients on Herceptin. And if you need Herceptin, you're put on a waiting list. So you have to wait for somebody to die or somebody to finish their Herceptin before you can get on it. And they give only, like, I think, Ranjit, 9 cycles, isn't it? They only give 9 times, not one whole year. That's half a year. And if the patient wants to finish one whole year, they have to pay for the rest themselves. So that's what we do with just the adjuvant setting for HER2 overexpressed. We also have a problem getting the HER2 2+ doing FISH. Jane has just been to Malaysia. You know our problems with the labs there. And now you're talking about 1+. I just spoke to my pathologist, because now, because of this deruxtecan, they call 1+ positive. Everybody seems to need some form of anti-HER2 treatment. And The problem is the reproducibility. Between 0 and 1+, my pathologist said it's very hard to actually determine what is 1+. And also it depends on the antibodies used. Because some labs use cheaper antibodies to cut costs, and that might not be good. Perhaps Jane can elaborate on that.
Absolutely, absolutely, yeah. And speaking as a pathologist, the discriminatory capacity of 0 versus 1+ is awful. It's really painful because we never paid any attention whatsoever until a few months ago to 0 versus 1+. So you can't trust any reads that you see from the past of a 0 versus 1+. The other point is depending on which antibody you use, and there are so many different HER2 antibodies. You know, with one antibody, you know, you'll get a 2+, and another it's a clean 0. And so that, you know, you just cannot compare. The immunohistochemistry is it's just not the right assay for these, you know, for these ADC drugs. We need to come up with a new assay, probably a quantitative protein assay, but that's going to add a huge amount of cost. I mean, it's going to, you know, it's not going to even be as cheap as a HER2 immunohistochemistry, and of course, most people cannot even afford the immunohistochemistry, the basic immuno.
And then what I feel is that you are actually proposing a new drug, and you don't even have a standardization of what is 1+, isn't it?
No,
so,
there's no. I mean, there's a guideline, but it was never ever meant to be discriminatory for the treatment.
Actually, it's a good thing the Rostican is not registered in Malaysia yet. If it is registered, can you imagine the problem we will face?
So, Cheng Ha, the only thing I would say, and I'm going to interrupt you, is that I think it will not take long before we actually do away with the monarchy results, and it's not going to be the 0. You know, it's not going to be discriminatory between 0 and 1, because we already know that HER2 negatives have plenty of protein. A subset of the HER2 negatives, the 0s, have plenty of protein on the cell membrane, and so they will respond. You know, it's just a short period of time, I think, before we have that data out there. In fact, is it Daisy? That's right, Dr.
Right.
Gralow.
And there's a Destiny Breast04 trial going on, and what were technically called 0s by our conventional methods that will be better exploring assays to show who might respond in that. But I want to get back, Shenghar, to your original comment, which is the country of Malaysia doesn't have enough trastuzumab, even for trastuzumab for all who need it. There is no way that in that setting, you should be worried about figuring out the HER2 low. You don't have access to a drug that benefits that. And I truly don't think we did a service to our patients with the 6-month versus 12-month trials and concluding that because 2 non-inferiority trials, one showed 6 was the same as 12 months and one didn't, so we decided everybody needed 12 months. Really, I don't think there's much more gain in the adjuvant setting from 12 months versus 6. And you know, I am very, very frustrated with trastuzumab is off patent. We have biosimilars. They're being made around the world. There should be competition, and we have not lowered the price accordingly. And that's something that Giselle and I last night, as she picked me up from the airport, were talking about. She brought up at our last meeting, our last CBCS meeting even, why are the biosimilar prices not being driven down enough? So that's another thing that we're going to have to come together on and work on. Because a drug like trastuzumab with multiple biosimilars out there, I mean, biologics are by nature a bit more expensive to manufacture than your typical generic drug, but they shouldn't be this expensive still, in my mind.
And one thing that we may be struggling in the region is there is such belief that using biosimilars these medicines are less potent or effective than the innovator drugs, and that belief and assumption need to be addressed as well.
So I just saw announced on Twitter, because that's my main source of medical information these days. Just this morning, when I got up, the EU, as a regulatory body, came out with a statement that biosimilars are interchangeable, period. If they are approved in the EU by the EMA, they are interchangeable. They have met the criteria to say there is no clinically relevant difference. I think this is another problem where we in the United States messed it all up, because we created this interchangeability category that nobody went for because it would be a lot of extra work to get the approval. And so there was an implication that if you just showed kind of equivalence but not interchangeability, that they were different. But just today, the EU kind of helped address that and said, looking at all the data with all the biosimilars we've approved, if it's approved, and I do think there might be some that aren't quite as good in other countries, then they are interchangeable. So.
Yeah, just one more thought on that is, I think the other way that we've hurt ourselves with biosimilars is the way we talk about drugs with each other and with our patients. So in fellowship, I was taught to speak about the generic name and never the brand name. But it is very tempting in clinic to say, oh, we're going to give you Herceptin. We're going to give you Avastin. And then that's the name that keeps getting repeated. And then all of a sudden there is this brand loyalty that's really not appropriate that develops. So in our institution where we have biosimilars to all of these, the onus is on the doctor not to refer to the drug by the trade name when we're getting consent. We say we're going to give you trastuzumab rather than say we're going to give you Herceptin. And when we get consent, we say we're going to give you trastuzumab, we're going to give you bevacizumab, not Avastin, not Herceptin. And I think that's one of the ways that docs communicate that can really help the process as well.
The Philippines was, we were fortunate to have biosimilar trials here from Mylin, Celltrion, and of course Pfizer. So a lot of our patients were able to participate in a metastatic setting as well as in a neoadjuvant setting. So, and of course you know that Herceptin is so expensive. It's really not affordable to a majority of our breast cancer patients. So we were happy with that. And it's true that in spite of the presence of the biosimilars, their prices are not really that down. And it still is not, there are still some patients, more patients who cannot afford the medicine, even in biosimilar stage.
And there's, just to add on what Dr. Kagiwa said, there's still another issue about clinical trials. Of course, that's a good way, a great opportunity for our patients to get access to the drug. But when the particular drug, and this happens with innovator drugs, not with biosimilars so far, when these innovator drugs get approval, for example, EU or in the US, even if patients from low middle income countries get the access through the clinical trials, some of these drugs don't get approved in the country or in the region. So that's one thing also that we have to think about.
So I don't have a good answer, and we're going to need to work together on this. But you know, we are working, the U.S. FDA is promoting multi-regional trials in registration trials. They've developed this project Orbis, where countries and regulatory agencies can work together on getting drugs registered. It is far from perfect. There are lots of issues with it, but we are recognizing this. And I just moderated a session at a meeting that's called the Accelerating Anti-Cancer Agent Development and Validation, AAADV. It was just a week or so ago. And my session was all on global drug development. And I actually had a speaker from Latin America and a speaker from Sub-Saharan Africa, just saying, assessing the ability of these regions to participate in big global registration trials. And one of the key points that we talked about was, it's not just about getting these other regions to participate in the trial. It's about, it is only fair if after the fact that the patients in these regions get access to the drugs. And that's got to be something that we buy into up front. And we've got a long way to go to solve that. But there is a lot more interest in doing true global trials to get drugs approved, and then the problem will be getting access, as you're saying.
And with radiation as well, and Dr. Mylin and Dr. may also join the conversation. There's a lot of issue as well with radiation access, and most of our patients with metastatic breast do develop symptom-related bone pains and body pains, and a lot of our patients, especially those who are living outside the city, in the rural areas, you can see how fragmented the healthcare system is, because they're being seen in one hospital and receiving radiation treatment in other hospitals. Perhaps more information you can share with our audience and those also joining us virtually on the SBRT. Can explain this to our patients. How is it being done? How do patients go through the procedure of radiation?
Dr. Yap. Dr. Yap.
Hello.
Do you want to take a stab at it first? Do you want to answer first?
Sure. First, I just wanted to say thank you to ICANSERVE and the Global Focus on Cancer and ASCO for inviting me to participate. So, you know, like the discussion about access to drugs, you know, we know that access to radiation therapy in the Asia Pacific is challenging, and you know, the Global Task Force on Radiotherapy and Cancer Control in 2015 with the Lancet Commission paper demonstrated that, you know, there's a huge deficit in access globally, particularly in low-income countries. And we know from colleagues at the IAEA that modeled that the Asia Pacific is the region which has the highest investment needs for radiation therapy, estimated around $10 billion that would be needed to close the gap in access in the Asia Pacific, and that's 3 times the amount of Europe. So, you know, it's a huge issue, and we know that radiation therapy is a cost-effective treatment. You know, it has the ability to both cure patients and to palliate distressing symptoms. I've heard from colleagues from the Philippines that there are issues around rural patients being able to get access to care. And we know that even in Australia and the US, that the evidence shows that patients who live greater than 100 kilometres from the nearest radiation centre have less utilisation of treatment. And I can only imagine that it's, you know, much more stark in the Philippines and some of the neighbouring countries in Southeast Asia. So I think the trial which Professor Mylin Torres outlined, I guess, perhaps for a resource-constrained country, it might give some, I guess, help to, I guess, for countries where there's been, or centres where there's been concern that perhaps they haven't been able to get stereotactic body radiotherapy up and running as fast as they'd like. And I know there are a lot of centres in the Asia Pac that are really trying to get SABE on board. That, you know, in this setting at least, for this patient cohort, patients with metastatic hormone-sensitive breast cancer, that perhaps treating symptomatic lesions with something as simple as a single 8 gray and 1 fraction is a good treatment. And I think that clarifies that in the sense that, you know, it hasn't shown that giving SABE is actually leading to progression-free survival or overall survival benefit, at least in that cohort. So I think it does clarify that, you know, giving single 8 and 1 for for bony mets or other metastases that are causing pain or symptoms is a good treatment, and if you're resource constrained, then that will allow other patients to be able to get access to radiation therapy because you have more throughput on the machine. So I might leave it to Dr. Torres to also take over from here too.
So I agree with everything that Dr. Yap just mentioned. I would say for SBRT, what she was mentioning, the 8 grade times 1 and what I discussed, it's actually a relatively safe treatment with traditional radiation, 3D conformal therapy, or even 2D. When you get into SBRT, it's inherently elevated doses, which can be dangerous to critical structures like the heart, the lung, the brain. And it involves an entire team of people, not just the physician, but physicists and dosimetrists, radiation therapists who are all making sure that the patient is lined up exactly within 3 millimeters for this treatment that is so precise. And you have all of this equipment, we call it even saran wrap, where the patient is like wrapped in saran wrap and held tight, and they have to be in this position, and onboard imaging where you can see with a CT scan how tightly they are to the day of the planning session to make sure that the patient is not moving and you're not hitting a critical structure with this high dose of treatment. And then you've got the QA with the machine that the physicists have to do on a daily, weekly, and then monthly basis. So I think in a setting where you don't have a whole lot of resources, SBRT maybe not makes the best of sense, because even with the 8 grade times 1, you can repeat it. If the pain comes back, you can repeat it like even as early as 3 to 4 weeks after that treatment has been given and get pretty good durable pain relief. The trial I mentioned out of MD Anderson, it's a signal that SBRT might give you a more durable pain relief than 8 grade times 1. It might last longer, you might have more relief, but it's still a phase 2 trial. We're waiting on the phase 3 data, and given all of the production, if you will, around SBRT, I think it might be something that in the future we can think about, but for now, in a practical sense, it's not so practical when you think about all of the constituent parties that have to be involved to deliver this treatment safely.
Yeah. Hello. Yeah, I'm Dr. Lorenzo. I'd like to add, the SBRT study I think is very relevant. It's really an example on how all these new studies can bring data to us, so how we can use the studies properly. Most of us in our practice are very tempted to radiate oligometastatic disease when they're 3 or 4. And I think this is a lot because we have these anecdotal stories of patients, especially coming from colon cancer. At one point in our practice, we were always told that, if you do local therapy to metastatic disease, it is a systemic illness, only to find out that in fact there are advantages, at least mostly for colorectal. So a lot of our colleagues now, myself included, is very tempted to have this small, low volume tumors from breast cancer radiated. And I think this study is very compelling. And it probably guide us, both medical oncologists and radiation oncologists, how to treat patients. And it's ASCO 2022, which is the theme of today's conference, as we translate it into the third world, I think it's the responsibility of our physicians to take the data, and to really discern, because the internet is faster than the ability to access and to pay for the medicines. And it's sometimes the hype is so big that our patients are not able to access it and to pay for it. And when they end up getting the WASC gold standard, you almost kill them because they feel that there's something very new. So I think we have to be more responsible.
So negative trials are just as important as positive trials, right? Telling us what not to do is just as important as what to do. And you started, Rizal, by talking about tamoxifen versus aromatase inhibitors versus the, fulvestrant. And, tamoxifen is still a really good drug. And it's probably the breast cancer drug worldwide that's had the most impact and saved the most lives. So we can't forget about these old drugs that have been generic forever that have nobody really sponsoring the trials and all. And we can't be giving up some of these simple therapies that are actually quite effective. And now it's our obligation to talk to our patients about that balance as well. So thank you.
Great discussion. We will still have more for this session. So at this point, we will move on to the segment where we will be discussing a patient case. So are we ready with the slides? So our reactors and our speakers, you may stay seated. For those who are joining us virtually, we invite you to forward your questions via the chat box. And for those who are joining in person, please take this great opportunity to share your insights or give comments and questions to our speakers and reactors. So our patient is a 39-year-old, married with no children. She's an office employee, lives outside the city, no past illnesses, and no family history of cancer. In 2017, she was diagnosed with invasive ductal carcinoma stage 3A, had MRM on the left breast, tumor size was 3.5 centimeters, grade 2, and positive metastasis to 8 axillary lymph nodes. Her tumor was hormone receptor positive, HER2+1. She received adjuvant chemotherapy, doxorubicin and cyclophosphamide for 4 cycles, followed by docetaxel for 4 cycles, and adjuvant tamoxifen. She was advised to have adjuvant radiotherapy, but she did not comply. 2 years later, she experienced cough, weight loss, back pain, and difficulty walking. Her CT scan showed multiple liver and lung nodules, which are metastatic lesions, as well as multiple bone metastases. Her brain MRI was normal. At the time, at the discussion of what will be the next best treatment for her, which of course everybody would agree to have a rebiopsy to check on the current status and biomarkers of the tumor, she did not agree. So she was given, based on the original biomarkers, the panel, hormone receptor positive, HER2 negative at the time, +1 was the reading. She received paclitaxel and carboplatin with zoledronic acid, and she developed partial response. And then in 2020, there was progression of the metastatic lung nodules after receiving the 9th cycle of combination of pacli-carbo. Then her treatment was shifted to capecitabine, an oral chemo drug, for 4 cycles. This was at that time at the height of the COVID-19 pandemic, when there was strict community lockdowns. After 4 cycles of oral chemo, she had progression of liver and lung nodules, and then she was prescribed CDK4/6 inhibitor but was not able to comply due to cost. So at the time, August 2020, she received goserelin and anastrozole, and up to this time, current time, the patient is doing well. So we look forward to more interesting discussion anchoring on the case of the patient. Are there any questions from the audience? Yes, Dr. Chenghar?
There's a lot of emphasis on actually getting the exact percentage of ER, PR, and the intensity of staining. So do you have the percentage of ER positivity and intensity? And maybe Jane can tell us, is it essential to do the percentage and the intensity?
I mean, absolutely. It is, because when you have 10% or less, I think most of the time you're going to treat that patient much more aggressively as if they are an ER negative, because we know that there's a subset of those who are really not going to respond to endocrine therapy.
I would agree. Well, it still might be a little complicated in terms of, you want to know, is there a lot of estrogen receptor expression or not, is what you want to know. And I think we haven't had 100% agreement as to it's the percent of cells and the intensity of staining on each cell, or do you just report the percentage of cells? I'm not sure we're uniform about that, but absolutely in answer to your question, Cheghar, you want to know, is there just a little weak staining or is it really strong in a lot of the cells? Because this patient was treated first with chemotherapy, presumably because she was quite symptomatic and it was felt that we wanted a quick response, and that's fine. But she's done well for almost 2 years now, if I'm reading her case rate, on just ovarian suppression and an aromatase inhibitor. And I might have, if I really thought she needed chemo first, because of her symptoms and wanting to get a quick response, I might have quickly switched her then over to endocrine therapy at that time. But you know, you never know. You have to be there seeing the patient to know what's right. But in answer to your question, I would have wanted some sense up front. Is it just really weak estrogen receptor staining or very high staining? Because that might have really made my decision about what I recommended, endocrine therapy versus chemo.
Right, and I think if this patient had presented here, the ER intensity would have actually gone into, at least for me, surgery versus neoadjuvant approaches. So if this was more staining low ER, I would have probably more aggressively been in favor of a neoadjuvant chemotherapy approach prior to her surgery. Will it make a difference in the adjuvant setting if it's ER 1 to 5% or PR? Would I not give her endocrine therapy? I still would give her endocrine therapy for the possibility she'll respond, although the way I explain it to people is we're going to give you this treatment because you have low ER positivity, but I'm going to have a very low threshold to discontinue it if you cannot tolerate this thing at all. Now, the other thing is I think the radiation therapy was critical. Maybe you could chat about that because of survival advantages of the radiation.
Most definitely. As far as radiation in this scenario, a very classic and, you know, no questions. This patient had 4 more positive lymph nodes. They're going to need radiation, whether they have a mastectomy or breast conserving surgery. It's been shown to decrease local recurrence, regional recurrence, and also prevent distant metastasis, even upwards of close to 8–10% in someone that this high risk with such a young age. So in the U.S., typically she would be given 5 to 6 weeks of radiation. There was a randomized trial out of China saying that 3 weeks or so is just as good as 5 weeks, and one out of the U.K. as well, showing that 3 weeks just as good as 5 weeks. We've been slow to adopt it in the United States for a number of reasons, but that would have been the typical radiation course.
Yeah. I think one of the take-home lessons on this case, as Dr. Dizon alluded to, is, you know, if this patient was seen in a collaborative manner, you know, to our patients out there in the audience, I think most of us would have agreed that this patient would have benefited from induction chemotherapy. This is a patient with probably stage 3, you know. So I think we should, you know, educate the patients that, you know, it takes a village nowadays to treat a patient. And then the other take home is, you know, oftentimes in our practice, and not limited to breast cancer, but when you have all these new drugs, and you know, and they're the gold standard, it's so difficult to separate what science tells us, as we have to be beholden to what all these studies do. But at the same time, it does not always necessarily mean that the new one is always best. In this case, I think we would all think that chemotherapy would have been the appropriate treatment for this patient who had a lot of visceral mets and symptomatic, but only to find out, you know, that it was a very benign combination of anti-hormonal that was able to stabilize her disease for 2 years. So again, when we speak with our patients, I think we first have to also know who we're talking with and to listen first. And you know, sometimes what is newest and what appears to be best. There are other options, and I think we're forced to think that way when we live in a developing country like ours. It's not easy. It's every time it is part of the equation when we make decisions. You can talk about the science and all for the first 20, 30 minutes with the patients, but in the end, it's that last 5 minutes that count. So we're just sharing with the group.
They're sharing the importance of MDT, having all the specialists, the doctors, not only the surgeon and the oncologist, but the whole team, having a patient-centered approach. Dr. Kagiwa?
Yeah, I think we, as much as possible, we really do multidisciplinary management. But be that as it may, this patient was not given neoadjuvant with that quite advanced. But of course, in her setting, she would have been a candidate for CDK4/6 inhibitor and hormonal therapy. But it was quite prohibitive. The prices are really quite prohibitive. And of course, at the time, this was 2019, I think, right? There was no, how do you call this, support yet from some pharma regarding to bring down the price or to make it more accessible, to make it for patients and more affordable.
We have another session about locally advanced breast cancer, which Dr. Cheng Har and Dr. Rosita Malik will be talking about. So I hope our participants and our attendees will be able to attend that session as well. And going back to the hormone receptor expression, Dr. Brock and I were together in a meeting in Malaysia, and we were informally talking about what about those findings of having an ER negative and a PR positive disease. How do the pathologists look into this, and how do our medical oncologists treat these patients?
Yeah, I have 2 points to make about that. One is that the ER negative, PR positive does truly exist. It's very rare, but we do see them. Usually it will be a very low level of PR expression and ER negative. The other thing I would also point out is you really, when you get those cases, you have to look at what PR antibody your laboratory is using. There are some PR antibodies out there that are a little bit too sensitive. They can score positive when they're not truly. They're really false positives. So it's actually very difficult to know, and if unless you're looking and unless you've got that expertise to know whether you're dealing with a false positive PR or not. And then, of course, added onto that, we don't actually know the biological significance of being ER negative and PR positive when it comes to response to therapy.
Jane, do you use Ki-67 at all when you usually see an ER negative, PR positive tumor?
No.
No.
But tomorrow, Dr. Brock and I are doing a full hour on Ki-67 and HER2 low. So if you're interested in either of those topics, we will be discussing those in more detail.
Yeah,
Julie, you can pay me later for that.
I do realize I said monarchy earlier, and I actually meant the Destiny trial when I was talking about apologies for that.
Just change the case scenario a little bit. For example, if this patient also presented with asymptomatic brain metastasis. So this is one common scenario as well that we see, and medical oncologists quite struggling how to approach, of course, regardless of the hormone receptor status, HER2 status, but how soon or how urgent it is for radiation oncologists to provide treatment. Dr. Yap, would you answer that or give response to that?
Yeah, I think it's a difficult one. I think it really depends on the patient and the number of brain metastases, the location, whether or not any of these metastases are located somewhere that we're concerned about, and and also I guess what other treatments this patient has had and the overall prognosis. We'll always, if it was in our clinic, I would always see the patient. to see them, assess them, and discuss the options. And, you know, it can be that, you know, we have stereotactic treatment available in our centre, so if there's in particular one lesion that's the largest and concerning regarding, you know, imminent symptoms, then it could be that we could treat that lesion first, or it could be that we continue to observe with MRI surveillance. I think it really depends on the number, the size, the location, and really case by case. But interested to hear what other colleagues are doing in this setting.
So at our center, and even in my training at MD Anderson, we were very aggressive. When the lesions were found, we treat them right away. And I think part of the thinking behind that is that a lot of the drugs don't penetrate the brain that well. If you find it, you want to just go ahead and treat it and move on. And our center tends to be very aggressive with the stereotactic radiosurgery, and we'll treat even up to 10, sometimes even more, with stereotactic radiosurgery to spare cognitive toxicity that you can get with whole brain radiation. So that has been our approach.
Even with symptomatic visceral metastasis?
With symptomatic, yes.
Visceral metastasis.
Mm-hmm. And even post-resection, we'll do stereotactic radiosurgery to the cavity, the surgical cavity.
Was your question, what if they had symptomatic liver metastases? Would you still... I wasn't sure I understood.
Did you say liver or brain?
Symptomatic lung metastasis where patient is having coughing and shortness of breath.
Yes, so in those scenarios, it depends on how large it is. If it's greater than 5 or 6 centimeters, we'll then do a little bit more of a fractionated treatment. But that's something that's smaller. You could give a high dose treatment that's going to be just a few fractions or a few treatments.
So in an ideal setting where you have access to TDXD, and Dr. Gralow presented that data on Destiny Breast 04, how would you sequence treatment for this patient? Dr. Lorenzo, Dr. Kagiwa, and Dr. Dizon may share.
Yeah, you know, I would actually love the audience's opinion on this. I'm trying very hard to stick to the protocol that Destiny 04 provided. So I'm not using TDXD as my upfront treatment in metastatic disease, and I am using it before I feel I need to go to chemotherapy in the hormone positive context or after one line in the triple negative context. What I'm struck with, and the struggle for me, is treating HER2-0. And I have, you know, several patients, subjected them to multiple biopsies trying to find HER2-1 plus. And I actually posed a question on Twitter about whether or not my colleagues on social media would ever use TDXD on HER2-0, and there's no consensus about it. Jane, you mentioned the DAISY trial out there. You know, having looked at the data, it doesn't seem that promising if something is actually HER2-0 compared to HER2-1. But I think what you mentioned is the absolute next step in doing HER2-0 versus 1.
Yeah, and I would just say, if you want to get a 1+ stain, ask your pathologist to use the Herceptin antibody, and you'll get a 1+ out of it.
I even went as far as sending the path a second opinion to Boston.
Oh, you wouldn't get one out of us. We use a very clean antibody, so we have very few 1+s. It's actually on it, yeah. But you can create a positive result very easily.
Because I mean, I've heard it from pathology that there is some expression, you know, in breast cancers for HER2.
Well, if you think about it, I mean, we know there's one published study looking at quantitative protein levels to try and separate out the very low levels of expression of HER2 protein. And I think it was 67% of all cases tested fell into a detectable level of protein on the cell membrane, but that fell below the amplified cases. So, and an awful lot of those were HER2 negative by immunohistochemistry. It's just not the right assay. The assay is just not sensitive enough.
what is important as well is to educate our patients that whenever they experience disease recurrence or disease progression, is the importance of rebiopsy, right? Because the treatment will be different from, if we will base the treatment from the original breast panel that was done on the primary tumor. And perhaps, Jane, you can share more about your experience on the heterogeneity and the differences in the breast markers on the primary tumor and on the metastatic lesions.
Gaining HER2 expression is not particularly common. It's, you're more likely to, if in the neoadjuvant setting, we're more likely to see a loss of HER2, but even that is not that common. It's, the statistics, I think they're around about 10% change, but it's really not common that we see a change between the primary and the metastasis with HER2. We absolutely see a loss of ER expression, particularly now with the patients getting SERMs. It downregulates the ER, so you have an ER positive tumor, and they very commonly become ER negative, after a year or two of treatment. And again, I think Dr. Gralow could probably comment, or you could comment more on that.
And the development of mutations in the estrogen receptor gene that may have implications for resistance, particularly to aromatase inhibitors. But there are many things that can change, and it's not just the ER or the HER2. And I think getting genomic profiling and retesting, now I want to do PD-L1 testing if they're triple negative. I want to know about PIK3CA if their tumors ER positive. But I also, we've got these blanket approvals if you have microsatellite instability or a high tumor mutational burden for immune checkpoint inhibitors. Sometimes I can see somatic mutations in, for example, BRCA1 and BRCA2, where we've got at least some data that suggests the PARP inhibitors that work with inherited mutations might also work if the tumors developed a somatic mutation. So, and there are many other things that there might be implications for therapy and that can change over time. Now, ideally, breast cancer isn't like lung cancer, for example, where you can get a liquid biopsy and look for some of these changes easily. Especially a breast cancer that's predominantly in the bones and that's ER positive and it's not very aggressive, you're going to have a hard time finding it in the blood. As opposed to maybe a more aggressive triple negative that's in the liver, you can do a liquid biopsy and just find some circulating tumor DNA. Lung cancer, you frequently can find it in the blood. So I think we've got to make biopsies easier too and more reproducible, and then we'll have the opportunity to check more often over the course of treatment.
Stressing also the importance, as what Dr. Gralow highlighted, that personalized treatment is something that's very, very important for patients to understand that breast cancers are not the same, they are different. And the oncologists and the clinicians base their treatments on how the disease is behaving, not only on patient factors, but also on tumor factors. So these are very important information that patients should understand, that it's quite frustrating for some because they don't have the patience of doing these tests, especially in developing countries where you don't, doing NGS or all those panel are not reimbursed. So you tend to limit what are the specific tests where there is an available drug. For example, if there is a mutation that can be discovered, so the other panel cannot be tested just because, or perhaps the drug may be available, but the access due to cost may be too expensive for a patient to sustain all the treatment cycles. So these are the limitations, and these are the real thing that's happening in the Philippines and in other low and middle income countries. Dr. Brock, you're about to say something? Dr. Kagiwa.
Professor Gralow, you mentioned that 55% of metastatic breast cancer is HER2 low. Is that really the statistics? Wow, that's more than half. Okay. Yeah, if that's the case, we have this drug now, but I'm sure it's going to be very expensive and no one maybe can afford it here in the, very, very few can afford it here in the Philippines. So, and of course that also, if you're saying that pathology is important because the antibody that's being, the HER2 testing is crucial, whether it's HER2 low, the +1 or +2. So does that mean that we have to retest some of our patients? And then if they can be eligible to get the drug?
That's why I keep biopsying some people.
Yeah.
But it's really important you have a good relationship with your pathologist because they are very aware of this data as much as we are. And, if you are, I'm actually pushing our pathologists now. We do have a metastatic breast tumor board where we are not, accepting, oh, it's HER2 negative. We're actually saying, was there any HER2 expression at all? I think it's a really important thing to have that relationship with pathology. But I think the second thing, and Julie mentioned this, it's not a benign drug. So, it's been surprising when we talk at our metastatic tumor board about using TDXD, some of the reluctance comes from the oncologist because the interstitial lung disease is a real toxicity signal, and if you look at how the label ended up being constructed, the first sign of toxicity, you have to stop the drug. People with more experience with this will tell you can actually do steroids, you can watch it and prevent it from going to a grade 4 or 5 that's going to kill this person. But I think that there is reluctance from medical oncologists in the US of using TDXD.
Right, and unfortunately, when we first started using it, COVID hit shortly thereafter, and so there was this concern if you had a little bit of a cough or a little bit of a chest x-ray finding, is it the drug or is it COVID or what? So it was a bad timing in terms of when it got approved for the HER2 positive. I would say at this point, if you are certain that there's no way to get your patient access to this drug, then you should not be worrying about the HER2 low, right? I will also say that this is a perfect example of a drug that would not make it onto the WHO essential medicines list solely because of cost. It meets the 6-month prolongation in survival. It would meet the other criteria, but it would be cost. And this is exactly the kind of drug that we hope to include in our ATOM coalition, our Access to Oncology Medicines, because it would be on the WHO's essential medicines list if not for the cost. And so that means we need to partner with the company, AstraZeneca, see if this is 50% of metastatic breast cancer is a huge number of people in the world. Based on this new potential market, can we bring the price down, or can we do, at least in low and low middle income countries, some kind of, this is our example of the voluntary licensing in the medicine patent pool, where we could get access for the low and low middle income countries to a drug like this that would otherwise meet the criteria for the WHO's essential medicines list if it weren't for the cost. This is an important drug. It has a real survival benefit, and we've got to figure out strategies to make it available.
So just to add to the discussion about the toxicity with TDXD, a lot of these patients will need radiation to palliate symptoms. And so one of the questions that we have is, how do you interlace the radiation with something that can cause interstitial lung disease? When you give radiation to the lung, you can also cause pneumonitis. So are you going to make things worse for the patient by combining those two agents together? So I'm working with a medical oncologist at our institution to help and try and look at that question. Can you combine those two treatments together safely and effectively for patients like this?
And I clearly remember when the data on Destiny Breast 04 was presented in the ASCO plenary, after Dr. Modi finished the presentation, there was a standing ovation. So you can see how the impact of this new drug made to a lot of patients, especially in the U.S. So, but we are very much looking forward to have the drug available in our patients in Southeast Asia. Any other words, Dr.
Well, I was going to say, do you know what the only other standing ovation I've ever seen at ASCO was? It was the adjuvant trastuzumab presentations, which overspilled into 2 rooms worth of people. So, and I think the reason it got a standing ovation, it wasn't just the drug, it was a total reclassification of pathology, and we've created a new category of breast cancer that we never had before either, you know. So it was the combination of both.
So everybody will agree that this is a wonderful discussion. We thank our speakers, our reactors, and Dr. Yap, thank you for joining virtually. So we have so many information and thoughts from this session, and we hope to see you tomorrow for another interesting discussions and sessions. Thank you very much.